All right, everybody, good evening, and welcome to another online lecture brought to you by the AMSSM Fellow Online Education Committee. I'm going to be your moderator, Dr. Myro Lu. This national lecture is sponsored by the AMSSM Education and Fellowship Committees. And the purpose of these lectures is to serve as an adjunct to your individual's program's educational programming. It provides fellows with direct access to educational experiences with experienced AMSSM members and invited guests. These lectures will also help assist in the CAQ exam preparation. As a reminder, if you haven't already, please mute your device's microphones and turn off your video. After the program, please complete the evaluation, which we send at the end of the lecture. And please submit any questions through the chat function, and we will try to get through some of them at the end of the presentation. So tonight, it's my pleasure of introducing our speaker, Dr. Jeff Leggit. Dr. Leggit is a professor in the Department of Family Medicine at the Uniformed Services University of Health Sciences in Bethesda, Maryland. He is the vice chair for the Family Medicine Department and the director of healthcare operations for the University Family Health Center. He is the clinical module director for the musculoskeletal curriculum for the School of Medicine, and he is one of the key faculty for the National Capital Consortium's Primary Care Sports Medicine Fellowship. He retired as a colonel with 25 years of service from the U.S. Army and is still giving back to the community by teaching the future of Army medicine and Air Force medicine. It is my pleasure to turn the screen over to one of my former teachers and friend, Dr. Leggit. Dr. Leggit, the screen is yours.
Okay, very good. I apologize for that. So let's go ahead and get started. I do not have any financial interests or relationships to disclose at this time. This will be our outline, and we'll discuss these in detail. I do want to point out that we're not going to cover thumb injuries, not that they're not important. They're actually very important, but they're a little bit more complex. So we'll just confine ourselves to the four fingers. So you have an injured index finger of the DIP while this young man is playing football. You may remember this is Russell Wilson. So this is one of the cases we'll discuss, and let's discuss a few variations. Here's your first patient. They come on in, and you see that their DIP is down in flexion. You do your ultrasound, and you see this finding, and you happen to have a handy-dandy MRI, and you find this. And we'll explain these a little bit later. They're all variations of the same condition. Patient 2 is here, and here's your ultrasound finding. I'll explain this a little bit more. Here's your third patient with an obvious fracture at the distal phalanx. Fourth patient with a larger fracture fragment. And your fifth patient actually has very similar to 4, except they have a volar subluxation of the distal phalanx. So these are all types of mallet finger. Patient 1 and patient 2 are tendinous mallet fingers. In patient 1, this is actually just a partial tear, but the tendon is intact. Patient 2 actually has a torn distal extensor tendon, but no fractures. Now we'll move on to our bony mallet fingers. And in patient 3, you have an avulsion fracture. So the distal extensor complex has pulled off a piece of bone, but fortunately that's less than 30% of the articulating surface. Patient 4 is a little bit bigger, and we're going to guesstimate that that's greater than 30% of the articulating surface. And 5 is really the same as 4, except that the distal phalanx is volarly subluxed. And so let's talk about mallet finger a little bit more and then explain the treatment for each of these. So again, this is a mallet finger, and what is it? It's a disruption of the ligamentous or bony attachment of the distal extensor mechanism, usually from a forced flexion where a ball or an object will hit the distal phalanx. And the patient will have an inability to fully extend their DIP on their own. The actual anatomy of the extensor mechanism is much more complex than I originally thought. One of the good things about going on to back to med school is you get to learn your anatomy a little bit more. And we teach the med students that there's actually a single extensor tendon, and this is the extensor tendon here. And then the actual distal complex that goes to the DIP is a compilation of this central slip, if you will, that extends, and then also extensions of the lumbricals and interosseous muscles, which come on into this lateral band And that's actually the extensor mechanism for the DIP. So it's a little bit more complex than I originally thought. And it's important to know that. And we'll go back to essential slip injury a little bit later. But right now we're going to focus on the DIP. So again, that's the anatomy of the extensor mechanism. This will be an example of ultrasound, which is going to be a high yield tool for you to help diagnose these and help decide what their definitive treatment is. And so this is a high frequency linear array probe. And then this will be the distal inner phalanx joint right here. And then we'll actually blow this up, and this is intact distal extensor mechanism, and then we can ask the patient to flex their finger, and you'll see this move, and you'll see there's continuity. This is a long axis view, and this is a short axis view, which brings up another point, is that you're going to see your pathologies in both views, in orthogonal views, and you really do need to confirm that. If it's truly pathologic, you'll see this in both views. And I'll be honest, I don't always do the short axis view. I should do it more, but I will say I'll do it when I really see there's an injury on there. So again, here's our normal. And here's some references for you too. And so actually, how do we test for a mallet finger? To test the DIP joint, what you're going to do is you're going to fix the PIP, and you're going to ask the patient to actively extend their DIP, either against resistance or by themselves, but there's either force or there's no force at all. If there's a minimal amount of force, then it's really incumbent for you to find out how many fibers are intact. But again, you have to fix this PIP, and then you ask them to extend the DIP. We're going to talk about central slip injuries in a little bit, so I'll go into this test a little bit later. But ELSON test is a test for central slip injuries, and I'll explain those in a bit. So right now we'll just focus on the mallet finger. From this article here, there are multiple classification systems, and really none are perfect. I like this one because of its simplicity. And type 1 is just a ligamentous or tendinous injury. Type 2 is an avulsion fracture, less than a third or 30% of the articulating surface. A type 3 is greater than 30%. And a type 4 is really a 3 that has volar subluxation. Now, according to these authors, all three, the 1, 2, and 3, can be treated closed. And really, you only need to operate on a type 4 lesion. I'm not so sure I agree totally with that, and I'll talk about that a little bit later, but if there's larger avulsion fractures, at a minimum, I involve an orthopedic surgeon or a hand surgeon too, but this is a simplistic chart for me to think about. Now, to my knowledge, I haven't seen any of the classification systems tested in the CAQ, but it will be probably helpful to talk to your surgeons. And interesting, according to this article, really no surgical technique has been found to be better than another one, but we'll show those in a second. So I want to digress and talk a little bit about the healing cascade, and this is going to come important when we talk about how long that we need to splint these for. And so all ongoing process is along a 3-phase continuum, and this is true for really any muscle skeletal injury, bones, tendons, or ligaments, all heal in the same fashion. And so you have your initial inflammatory stage, which really lasts about days. And again, this is why we're remiss to give anti-inflammatories initially, because we do not want to shut down the inflammatory system. Then you have your repair system, which lasts about weeks, and then remodeling is months to years. Now, generally, our athletes will be able to go back to activity sooner than it's completely healed, but it's important to know that this takes months to years. Probably this repair portion is probably the most critical, because you do not want to interrupt this tenuous healing. And then once we actually break up that cascade, or we mess up the repair process, we kind of have to start everything over again. So it's important to keep these in mind: days, weeks, months to years. And so this comes into bear when how long we actually are going to splint a mallet finger. So a tendinous mallet finger, for it to get sufficient resistance, it takes up to about 5 weeks of immobilization. So that's why you'll see most literature talks about splinting for 6 weeks, so that we know that it takes about 5 weeks for tendons to heal. Turns out that bony injuries heal a little bit quicker. So this is, again, part of the distal end of the tendon remains attached, and it's just the bone that's actually pulled off, and those heal more rapidly. And so in theory, you could get away with a little bit less amount of splinting for bony mallet finger than you will with tendinous mallet finger. But again, repair lasts in weeks, which is where we get to, the 6 week is what we recommend on there. So again, keep that healing cascade. And this is true again for tendons, ligaments, and bone healing on there. The other thing that you'll see in various things in the literature, is how much is too much. Well, we know if it's less than 15% of a avulsion fracture, it's probably stable. And then, 15 to 40% is that kind of tenuous range. So you may see texts that say 25%, 30%, 40%. Arguably, those are, difficult to say exactly. But this is a tenuous zone here. And then if it's more than 40%, everybody agrees that's not stable, and that probably needs to see the surgeons for a surgical intervention. So I err on the side of caution, and then I'll discuss this with my surgeons. And it never hurts to have them take a look at the films, and we can discuss those together. But this tenuous zone is something to keep in mind. And again, that's anywhere from 15 to 40% on there. The other thing, and this goes back to that, so if you have a large fragment, it's probably unstable, and you risk that thing actually having the distal phalanx come into a volar subluxation. And that's just not a good thing at all. So again, larger fragments, I'll discuss with the surgeons and at a minimum co-manage, if not let them manage them themselves. So driving on to the treatment. So the treatment is keeping this DIP joint in slight hyperextension. Again, this is where we get this number 6 to 8 weeks, because it takes a minimum of 5 weeks to heal that tendon, 24 hours a day. And if the splint comes off and they go into flexion, that clock has to just start all over again. So again, 24 hours a day. The literature will say that you can do this up to 6 months. I've actually done longer, but the literature will say that you can do this up to 6 months. And then once you've done this for 6 to 8 weeks, most people will say that you need to continue to wear a splint with activity, certainly during the season. And for our military athletes, we would err on the side of caution, and we would splint while their activity. We used to talk about splinting at night, but a recent article I read really has called that into question. It's probably not necessary. And if you've ever worn these splints, they're not that comfortable, and they can get smell and all sorts of stuff. So the literature has not borne out that wearing it at night after this initial 6 to 8 weeks, it seems to be as important. Most people agree that to continue to splint or a minimum buddy tape during activity. And here's another good thing, depending on what their position is, depending on what their occupation is, they can still play or proceed if this is protected adequately for their sport. And so remember who to refer. Large avulsions, and in my mind, anything more than 25% really should be discussing with the surgeons. If you have something that's subluxed, or certainly if you have an open wound, a laceration, that probably needs to be referred on there. And so mallet finger treatment, if you do not treat, you might risk a swan neck deformity later on. And then if we're going to treat closed, which splints, and we'll talk about that in a little bit, and there's quite a variety of them, and none is really better than another one, but there are a few pros and cons, and we'll talk about that. I'll show you the different splints, and some people argue that you should use different splint types to avoid skin breakdown. And then the other question that really hasn't really been answered is how often do you follow these patients up? Certainly if there was an avulsion fracture, I would probably follow them up a little bit more frequently, but there's not an exact time frame. The other thing for me that dictates frequency is how compliant I think the patient is. And we'll talk about when I show you the splints, what I mean about that. And who should you consider to operate on? Certainly if the athlete desires an operative management, that's something to consider because they may be able to get back to their sport or occupation a little bit earlier. We already talked about the volar displacement. If you feel like you need to reduce it and you can't reduce it, then there's probably some soft tissue or bony elements in there, and that should be referred. And again, large fragments need to be referred on there. So there are various splint types. We're going to talk about them, but remember this can be purely tendinous, so there can be avulsion. So this is kind of one that we have in the field, and this is an aluminum foam splint that you can cut to the proper length. This is your traditional stack splint, and this is probably the most common. And then this is one I came across that's either called a ring splint or an oval 8 splint. And I came across this when I actually did this to myself in mallet finger. And these all will get sweaty and smelly And it is near impossible to change these yourself. And so unless you have a partner around that can help you with that, or you're going to have the patient come into the clinic every 2 days, if you want them not to actually have this thing bent down, then you're going to give them some device like this. And I was able to change these myself. I had a couple of these, and so I could wash the other one out. And so I would just encourage you to consider doing looking into these splints. The other thing is that there's a wider side and a smaller side, and so the swelling subsides. You can change that, and then you can use these type of splints for also your central slip injuries, for your collateral ligament injuries, your volar plate, which we'll talk a little bit better. And I don't make any money off doing these. I just found these myself. But again, I just wanted to reinforce it is near impossible to change these splints yourself. And so you need to ensure some compliance. And so if there was someone who I didn't feel comfortable with, I would bring back frequently to watch them splint change. And I would actually say every patient I'll have come in at least for the first 1 or 2 splint changes to make sure they're doing that and they're keeping that extension. So again, these are a variety of splints that are options for you. So what are some pitfalls in managing a mallet finger? Well, if you hyperextend it too much, I've seen this, you'll macerate the skin. So you don't want to do that. And we're really only splinting the joint that we need to, and that's really an axiom for any splinting that we do. So you don't need to get a big old aluminum splint and have it go back to the PIP. So again, don't splint the PIP. And then you should never splint a sublux joint. And so it's probably not a horrible idea to re-x-ray these after you splint them to make sure you didn't do something inadvertently on there. There's no an absolute, but again, you definitely don't want to splint a sublux joint. And then don't make the splint too tight on there, because again, we do not want to cause any maceration. And certainly if you're seeing blanching to the skin, that's too tight. And also warn your patients that there'll be swelling, depending on how acutely you see this, and that with swelling, they may have to take the splint down and readjust it so it's not too tight. And then again, do not allow any flexion for up to 6 weeks, remembering that healing cascade on there. And if you do, the clock just starts all over again. And so I alluded to earlier, there is a role for surgery in mallet finger. And again, so those that you can't reduce, a big fracture fragment, if they have a delayed presentation, the literature will say 6 months. And then again, failed conservative therapy, i.e. they're not compliant, or they just failed your therapy. And again, for early treatment for athletes or some occupations, you can consider a surgery. And this is one of the options where they'll put a K-wire here. And you see they've clipped this end so they're actually not sticking out. So this person can actually possibly go back to their job or their sport if they so desired. And there'll still be some precautions, but that's an option for your patients to pursue. So shared decision making. Okay, so moving on from mallet finger, let's go a little bit further back. And so this is a horrible term, but this patient jammed their finger 3 months ago now, and it's stuck like this. And the question is, what is this condition? And this is what a boutonniere deformity is. And this is important. So a boutonniere deformity usually is a result of us not treating this properly and or the patient not coming in on a timely basis. I actually gave this talk to our fellows yesterday, and they said, well, what time frame does a boutonniere deformity happen? I don't have an exact answer. The ones I've seen, the patients have been delayed anywhere from 6 to 12 weeks coming on in there. So I think it's probably in that 4 to 6 week window where that happens, but I don't have an exact answer of when a boutonniere deformity actually happens. But it is a late sequelae of a missed central slip injury, which we'll talk about a little bit more. So reviewing our anatomy, here is that central slip, or that common extensor tendon coming on over. And then this is actually looking up on the top view. And then, this is our interosseous, this is our lumbricals, and together those make the lateral bands. And so if you actually tear this central slip, it may cause a volar migration of lateral bands. And hence that's the reason for a boutonniere deformity, because these lateral bands have been allowed to slip on down, and they force this into flexion and force this into extension. So again, complex anatomy, but if this is torn, the lateral bands will slip down. And so I alluded to this Elson's test for essential slip injury. And so the way to do this test is you actually extend them over a desk, and you ask the patient to try to actively extend their PIP. And you're not holding the DIP, you're actually just holding this middle phalanx. And you should feel some force against your hand. And in addition, with the other hand, if you wanted to flick the DIP, it should be supple because these lateral bands are not engaging, and the only thing that's engaging is the central slip that's intact. So this is a normal Elson's test. And an abnormal one, this central slip is torn, so you'll feel no force on your finger here, but yet you'll have a rigid DIP because these lateral bands are engaged and they're actually extending the DIP. And so this is an abnormal Elson's test. This is a positive Elson's test. Now, I actually use this a little bit more, and this is called a reverse Elson test. I would say this is more in the CAQ literature, but you know, the hand surgeons I've worked with, and this is what I'll use a little bit more. It's the same principle. And so here, you're not leaning them over an edge of a table. You're actually still pushing against the middle phalanx. You should feel some resistance against your finger here, and then the DIP will be floppy because the lateral bands are not engaged. And then this one is abnormal. The central slip is torn. You feel no resistance at your finger here, and this is a rigid DIP because those lateral bands are engaged. So Elson test and reverse Elson test, again, keeping your anatomy in mind. And at this point, this would be a boot, maybe a boutonniere deformity the way they presented here. So I'm going to hammer this home one more time, so hopefully no one misses this if they have to take the CAQ, if they get asked by their attendings what causes a boutonniere deformity. So you'll get a flexion deformity from the unopposed flexure digitorum superficialis, because here it is here, and this is torn, so this is pulling down here. You can't extend the PIP right here. And again, if you don't correct this, these lateral bands are going to volarly migrate. So let's talk about position and cause. Extended DIP because the lateral bands have volarly migrated. You have a extended DIP because of lateral bands have volarly migrated. You have a flex PIP because the central slip is torn. The lateral bands are keeping in flexion. And then again, the flexor digitorum superficialis is pulling this, and there's nothing to oppose them. And so these are the reasons for a boutonniere deformity. So hopefully your patient comes in on a timely basis. Hopefully after hearing this talk, you recognize a central slip injury. And so what's the treatment? It's fairly easy. It's an extensor tendon injury. And so it's the same principles as a mallet finger. You want to splint the PIP in full extension for, again, that magic 6 weeks. And then you're going to buddy tape for a minimum of another 6 weeks on here. So again, the same principle of mallet finger, all extensor tendon injuries are treated the same way. And who do you refer? So again, a large fracture fragment, which arbitrarily we're saying greater than 30%, you should probably refer on there. And the other thing to think about is these avulsion fractures. And so if there's 2 millimeters or more, that's probably not going to heal. This is right on the cusp of that. And the surgeons can put a small pin in there, and that will help with healing. And so it's certainly worth discussing that with the surgeon. And I'll have an x-ray later that shows you one of those pins that are put in for an avulsion fracture. But I want to bear this in mind now that we're getting a more fancy and less invasive surgical techniques, that large avulsion gaps may not need to be accepted on there. And then again, if your patient presents with a boutonniere deformity, you should refer that on to a hand surgeon in addition to occupational therapy. And so these are variations of some different splints that you can use for central slip injuries, and so these are all ones with Velcro. And here's that oval 8 splint that I use for the magic, for the mallet finger. And you could use a slightly bigger one to treat the central slip injuries. So I find them quite versatile because I don't have a lot of these hanging around, and these are more in the purview of the hand surgeons, occupational therapy, but I certainly have these around. But any of these will work. And again, you got to keep that in extension for up to 6 weeks. Okay, so let's talk about our next case. And so this is a traumatic injury. So this happened the day before, and there was a forced extension, and your patient is unable to flex their DIP. And so what is this condition called? This is what is classically our jersey finger. And so here's a cartoon representation of someone trying to grab a jersey, and the athlete or the person's pulling away, and it forces an extension. And again, you have a tear here. We'll talk about different varieties, but just like in the mallet finger, where you can have a purely tendinous one, you can also have a bony jersey finger, as well as just a pure tendinous jersey finger. And so we discussed the anatomy of the extensor tendon. Let's talk about the flexor tendons. There are definitely two flexor tendons. So there's a superficialis, which is more volarly than the flexor digitorum profundus. And the profundus actually goes through the split of the superficialis, and actually it comes on here and attaches to the distal phalanx, and it's responsible for flexion of the DIP. I'm gonna actually make this a little bit more complicated, and so anatomy is a little bit more complex than just that simplistic representation I showed you. And so in this cartoon, what I wanted to show you is something called Camper's chiasm, which I'd heard many times, but I really wasn't quite sure what it is. And those are attachments after the superficialis splits into two. There are still some attachments, and that actually gives it a mechanical advantage. So that's actually what Camper's chiasm is. And then, with a really high frequency ultrasound, you can see some of that. But we're focusing more on the flexor digitorum profundus, because if you're going to have a jersey finger, that specifically is for the FDP. And so here's a little bit more detailed picture of the flexor tendons. And you see this FDP coming through the split of the superficialis. And what I want to bring your attention to is these structures that are called veneculums. And these are the structures that help provide the blood vessels to the flexor tendons. And we know if you don't have blood supply, things just don't heal so well, which is one of the reasons flexor tendons really need to be managed, primarily surgical for the most part, because they lose their blood supply. We need to get that restored. And here's an anatomical picture. You can actually see the A1 and A2 pulleys, which we'll talk about later. But here's those veneculums that you can see, and they're quite tenuous and they're not very strong, and it wouldn't take much to tear those things on there. And again, if you lose a blood supply, things aren't going to heal very well too. So driving on, there are different types of jersey finger. And so if you're asked, this is important to know that. And so type 1 retracts all the way to the palm. So you have a tear and the flexor digitorum profundus goes all the way to the palm. A type 2 will retract just to the PIP. And a type 3 is an avulsion fracture that kind of just gets stuck here at the DIP. And of these, the type 3 is probably the better one to have, because you have less space to traverse to put this back together. And then remember that bones can heal a little bit quicker than the tendons, and these are actually total tendon tears on there. So these are the different types. If you have to pick one, type 3 would be the one you want, but I wouldn't really want any of those, to be quite honest with you. And then again, here's a reminder of those veneculums, which is the blood supply to those flexor tendons. And so let's just talk about the physical exam of how to differentiate these, and obviously we'll talk about ultrasound in a little bit, but it's good to know these and to practice these. And so this one specifically is for the flexor digitorum profundus, which again is the jersey finger. And so what you're going to do is you're going to have to fix the PIP, and you're going to ask the patient to flex their DIP, and they can either flex it or they can't. You are allowed to go ahead and put a little resistance and see if you feel a strength, but they can either flex that or they can't flex that. And so isolating the PIP and then asking them to flex the DIP. If you're worried about the superficialis, this is the superficialis here, what you need to do is you need to keep all the other fingers in full extension, because that'll take the lumbricals and interosseous out of play. And then you'll ask them to flex their finger. And you can provide resistance at this middle phalanx, but either they can flex it or they can't flex it. And that's to test the flexor digitorum superficialis. So again, the profundus and the superficialis. But again, we're talking jersey fingers, so we're talking profundus here. And to be quite honest, I have not personally seen traumatic superficialis. I should say closed. The ones I've seen have been lacerations from a cut either in a kitchen, or a fight that went awry, unfortunately. I'm sure they exist, but I actually haven't seen those. I've only seen the classic jersey finger, which is digitorum profundus. And so fortunately, we have a tool called ultrasound that we can use. And this is important for diagnosis and also for surgical planning, because you would like to be able to tell the surgeon where the ends are, so it can minimize the incisions that they need to make. And so using a high frequency transducer, you can clearly see the digitorum profundus, and then you can see this structure, the volar plate, which we'll talk in a little bit later. And then dynamically, you can see this move, and you can see that the fibers are intact. So this is a normal flexor digitorum profundus. And here's an abnormal one on there. And so this would be a type, probably a type 1 or 2. So again, 1's all the way back to the palm. So, and we had talked about type 2 being here. So this is kind of in between there. But this is the cartoon version. And then you see on your ultrasound, you see a bunch of swelling in here. And then you see probably a fracture fragment. And then you actually probably see the end of the tendon. And then actually when we blow this up, or when we use a more high frequency probe, this is a little bit easier. Here's the fracture fragment. Here's the end of the FDP. And they wouldn't be able to move their DIP, and you could move it, and you wouldn't see any movement here. And so this would help the surgeon to know where that stump is, so that they can try to pull that back together. And so the treatment for all of these is to refer all of them. While they're waiting to see the surgeon, you need to splint in flexion, because if you splint in extension, that's going to extend that, and you won't get apposition. And so remember to splint these all in flexion. And then, the longest you should wait is no more than a week, preferably sooner. And really, I push for a day or two. But let's say something happened on a Friday and you couldn't get them into the surgeon until Monday, that would be okay, as long as you splint them in flexion. And again, preferably sooner. Probably the big thing is don't miss it. And so, whenever I see flexor tendon injuries, I really get worried about it. I want to make sure I don't miss anything on there. So again, treatment is to send all these to the surgeon for probable surgical intervention on there. Okay, moving on. And so this patient's finger got pulled back, which isn't a great term. So actually probably got extended or hyperextended, and it hurts right there where the bruise is. And so what would be the injury here? This would be a volar plate injury. And so here is a simplistic representation of the volar plate. And again, you'll have those over all these joints, the MCP, and then the PIP and the DIP, you have a volar plate. And here's more of a 3D representation of that volar plate, which is intimately attached to the collateral ligament, which we're going to talk in a little bit too. And in fact, when you have one injury, you worry about the other. So anytime you have a volar plate, you're always worried about the collateral ligament. If you injure the collateral, you're always worried about the volar plate. But what's its job? And so it limits hyperextension. So anything that hyperextends that joint would put that at risk. And then the other thing is it helps separates the flexor tendons from the joint space on there. And I had one of the fellows ask me yesterday, what actually is the volar plate? What kind of structure? I took a look, and these are they're ligaments, and so they help hold bone to bone. So they're a type of ligament. And I misspoke, and I said it was a capsule. It's really more of a ligament on there. And what's the injury? So the injury is a hyperextension, and the PIP is the most common. So right here, so it'll rupture the volar plate from the middle phalanx. And again, this will allow extensor tendon to pull out the PIP into hyperextension. But the key is you're going to have max tenderness of the volar plate, and so with some careful palpation, you'll know exactly where they're tender. And these can easily be seen on ultrasound too. And so, here was that picture that we showed earlier of a normal volar plate. And so here's an abnormal volar plate. And sometimes when there's pathology, it just doesn't look right. And that's the point. It doesn't look right. You don't have the structure that it used to. And so this is probably bleeding and swelling on here. And the good thing is with the fingers, you can always look at the abnormal normal one to go back and forth and see what they look like. And so, this should be what you're looking for, and you don't see that, and you see the swelling. And then remember I said that you're going to have pathology on both views, orthogonal views. So here's your long axis, here's your short axis. And again, there's just too much swelling. That's bruising inside of here. And you move over the next finger, and that's a good structure, a normal structure that makes sense on there. And so that would be a rupture of volar plate, and that would be a rupture of volar plate. So again, ultrasound is quite helpful. And it's also helpful to rule out some other injuries, because I told you I was always worried with flexors, and I can ensure that there's no damage to the flexor tendons here too. And so we diagnose an isolated volar plate injury. What's our treatment? And so really we just don't want it to extend, because that will not allow it to heal. And so we give them an extension block splint for a variable length of time. Literature talks about 3 weeks. How far do you put them into it? 15 to 30 degrees, that's quite variable, but again, you need to leave them in some extension. I actually have a little bit of issues with both these pictures, And one of the problems is that you're splinting the DIP and you're splinting the DIP here. And usually we want to limit splinting an uninvolved extremity or an uninvolved joint if we can. So you're better if you could just splint the PIP. But to be honest, in my clinic, I don't have this one here, and I have these, and so I end up, kind of manufacturing this aluminum splint on there. If the patients come in late, you're at risk for a swan neck deformity on there, and they'll have a flexion contracture. And so, this will be flexed and this will be stuck in extension. And those need to be referred on both to occupational therapists and to your hand surgeon. So again, treatment for volar plate injury is an extension block splint or splint them in flexion for at least 3 weeks on there. And then don't forget that if you have an avulsion fracture, and again, for sure greater or equal than 40%, that needs to see the surgeon. So that may need to be pinned down. And so they might put a pin right inside of here. And so I would refer that to the surgeons, and I would not personally treat that closed. Okay, moving on. And so their next patient comes in and their tenderness is just on the side, not on the distal portion, not on the volar portion, but just on the side of their DIP. And so this person has a collateral ligament injury. And so, this is a nice picture representation of a torn collateral, and these are quite similar to the collateral ligaments in the knee. And the testing is the same way too. And so this is torn here, but unlike the knee, you have this volar plate that comes into view, and we'll talk about that a little bit more. To add some more complexity, the collateral ligaments, there's actually 2 of them. So there's an accessory collateral ligament, and then there's a proper collateral ligament, and then there's this annular ligament that wraps around them, and then there's this volar plate that kind of attaches to all those too. So it's a pretty complex structure, but suffice it to say that if you actually try to open this up and you have gapping, you've probably torn all these structures, and that's a much more serious injury on there. And so again, this is another cartoon picture of the different anatomy of the collateral ligaments. And remember, you have a proper and you have an accessory collateral ligament. But what I wanted to show you is this 3D view is this intimate relationship with the volar plate injury. So, make sure that they're not all involved, because slightly different treatments, but again, they're intimately involved here. And so how do we treat these? So the question is it a sprain versus a complete rupture? And so again, they'll be tender on their sides. They should have normal active range of motion, both flexion and extension. And so that would rule out an extensor injury and a flexor injury. And then you need to test them, and they need to have no gross instability. And when you test them, you're actually going to flex this or actually unlock the joint to about 20 to 30 degrees, and then you're going to apply a valgus or varus stress as you will. And if there's gross instability that way, then you're actually going to put them back in neutral and then test it and see if there's still instability. And if there's instability when it's in its normal position, that denotes a higher injury, and that would be a complete rupture on there. And again, everybody's a little bit different, so you're going to test the uninvolved and see how much instability or how much opening it has. Now, the question that gets begged is, does pain negate this? And it can. And so you may want to consider, if you feel uncomfortable with your exam because of pain and you're not getting a great ultrasound picture of it, that you may need to give them some anesthesia, either just locally right here or digital block, so you can take pain out of the picture and see if it's unstable. Because complete ruptures may need to go see the surgeons. There's an axiom that you may want to get imaging before stressing, because if it's an avulsion fracture, you wouldn't want to make that worse. And so do I do that all the time? If I'm in the field, I probably don't. If I'm in the clinic, then I would get an x-ray before I actually do stressing, or I do a good ultrasound exam and feel comfortable that I don't have an avulsion fracture. But again, you don't want to convert anything and make it worse on there. And then again, remember that, if you have a collateral ligament injury, you want to rule out volar plate. And then if you have a volar plate, you also want to rule out collateral ligament injuries. And so how do we treat these? And so if it's just a partial tear, partial sprain, then you want to keep this in flexion, probably only about 2 weeks, although there's not an exact number on there. And then this, I would say I buddy tape. And the way I do is I buddy tape on the joint, and that allows some flexion. I do that for at least 4 to 6 weeks, or however long the season lasts. And I do want you to remember to warn your patients about swollen joints. I've had a couple of these myself, and my joints have stayed swollen. In fact, one was on my ring finger, and I had to get my ring resized, and it's never gone back to normal on there. And so just kind of warn them that may be the case. And then I want to bring this up to you. If you have a complete rupture, so again, there have instability both in 20 or 30 degrees of flexion and in full extension, then those should be referred on, or a large avulsion fracture, then you should refer. And see this piece here, this is too far apart, and the surgeon put a pin in here to attach that, and they healed much better, and so this will never heal on there. And so those would be folks that you should send to surgeons, especially on the radial side. Now, why do I say that a complete rupture and avulsion on the radial side probably needs to be treated more aggressive on the ulnar side? And the reason is because that's where you get your strength for pinching on there for your fingers. And so take those ones much more seriously on there. And I alluded to those small pins for avulsion fractures, and this is actually the size of the pin, pretty small, and that will attack that piece down there. Okay, moving on. And so this patient did not have trauma. They just come into you and they say they can't extend their finger and they hurt kind of right here, and maybe there's a little bit of nodule. So what is this condition? This is our classic trigger finger. And so, the technical term is stenosing tenosynovitis, or colloquially called a trigger finger. You can also have a trigger thumb, and so this is probably a better term. It's stenosing tenosynovitis, which yeah, and so this is a pictorial graphic that we'll use later to show our ultrasound pictures. And so remember, you have your superficialis, which is more volar. It splits, then the digitorum profundus comes in. And then in this picture, you actually see where your pulleys are. And so you have 5 pulleys. You have A1, 2, 3, 4, and 5. And the easy way to remember that is the odd ones are over the joints, and the even ones are kind of in the middle of the bone. So that's the easy way to remember it. A1 is much more common to have the stenosing tenosynovitis. And then this A refers here, and this is B, and this is C, and this is what we're looking for on ultrasound as we see the different flexor tendons. And then to get a little bit more complex, here are those pulleys. And the other thing I wanted to show you is there's some other constraints for the tendons. So you have these cruciform ligaments on here. And again, A1, A2, A3, A4, and 5, and the odd numbers are over the joints. So again, we'll kind of focus on here because this is where the majority of your trigger finger or stenosing tenosynovitis happens. And so this can be difficult to see on ultrasound for novice folks. And so I'm going to actually show you the short axis and long axis. And I actually like to use the short axis first, because to me, it's much easier to see these wings of the pulley. And what these wings are is no sound wave is coming through there. So it looks black on there. And so that's actually pretty easy for me to find. And then I'll go ahead and turn it to 90 degrees. And then that is the A1 pulley there. And I would tell you just on long axis, sometimes that can be difficult to see at times. And so I'll use this short axis view, and then I'll turn it 90 degrees and so that I can see the pulley. And then we saw this picture before, and I thought this was good to bring us in here. And so here's the A1 and A2 pulleys, and they're not really big structures per se, but again, use these wings to kind of help you. And that's going to be the same thing as you march distally on the fingers to look for the different pulleys. This picture actually shows the A2 pulley, which is, can be quite subtle. But again, this is what we're concentrating on for our trigger finger. And so there is a classification system, so it's probably good for you to know this. And so grade 1 is really just pain or tenderness at the A1 pulley. 2 is some catching, but they can actively extend their finger. 3 is it's locked and it requires someone else to unlock it. And 4 is you just can't do it, unable to passively extend, and it's a fixed flexor contracture. I will tell you that I have not seen 3s or 4s. They end up probably just triaging to ortho, and the majority of what I see is 1s and 2s on there. This is a representation of what those would look like on ultrasound. And so this is a 1 that's getting stuck, but the patient can actually unstick that themselves. And you can see some swelling up there. And again, this is actually what I end up seeing more often. 3s are not subtle. There's all this swelling on here. And again, they require passive extension to get their finger unlocked. And then again, you're never going to miss a 4. Just look how not good that that looks, because that's stuck on there. And so there is a grading system on that. I'm not so sure that I would treat these. I definitely wouldn't treat a 4 myself. I would involve a hand surgeon. Again, I'm not sure about the 3s, 2s, and 1s that I feel comfortable treating. So again, that's the grading system with ultrasound representation of that. And this is a nice side-by-side comparison, kind of marching down. So this is proximal to distal, both in our cartoon and our ultrasound. This would be abnormal, this would be normal. And again, there's those wings here, and there's swelling. And so that's just shouldn't be there. And you can flip on over to the normal finger, and you can see that that's swollen. This actual picture is right at the pulley. So this was a little bit more proximal. And remember, here's those wings of the pulley. And so this would be what an abnormal short axis view. Going just distal to the pulley, it just looks, you can't make the architecture out very well because that tendon is swollen, whereas you can make that out quite well. And then this is right at this pulley, because here's those wings again. And then you can see more swelling that you don't see swelling on the normal picture. So this is a nice representation of that. And so let's say that you decide that you're going to inject that, which is actually the primary treatment for certainly at least 1s and 2s, grade 1s and 2s. And so this would probably be the more traditional view, where you go long axis view distal to proximal, and you see the needle here. Certainly, there's nothing wrong going in plane proximal to distal, and that's all preferential. You can do that. And so there's a picture. And you can also go short axis in plane. And so this is my best example of trying to put the ultrasound transducer here. But this is a nice ultrasound view. And I actually probably do this one probably about 50 to 70% of the time. Because again, I can just see it a lot better. And remember, I told you I'm taking more grade 1s and 2s. And so I usually use this approach on here. One of the things you need to be worried about is the nerves and blood vessels using this approach. But I'll use this approach. But there's certainly nothing wrong with doing either of these approaches here. So all 3 of them are fine on there. And so the question is, how many injections should you do for trigger finger? And this has been looked at, and cost effective is 2 steroid injections. You're separated by, probably at least 2 to 3 months at a minimum on there, but that's probably the cost effective. And then if they fail that, they probably need to go see the surgeons, or you can percutaneously open that, and we'll talk about that a little bit. But cost effective is 2 steroids on there. And then the next question is, it doesn't matter where you inject. Should you be in the tendon sheath? If you're outside the tendon sheath, does that matter? And this isn't that old of a study. And the bottom line, extra sheath versus intersheath had no difference on there at the level A1 pulley. I would say it's cooler and better style points to get in there, probably minimize any steroid atrophy that you're going to have. But let's say you don't get that, or for some reason you're unable to use an ultrasound at that time, it doesn't matter. And I will say that most of the surgeons I see actually do not use an ultrasound. And I can't guarantee if they're inside or outside the sheath, but it probably doesn't matter. So I'll leave it at that. And then this is actually probably what we'll be doing as time goes on. We get a little more experience with it, but you can actually open this up with either a special needle, a needle knife, or there's ones that are like a crochet needle. And then an ultrasound guidance, you bring this in, you open up the blade, and you just cut the pulley. And this is swelling here. There's the needle, and now they've cut the pulley, and there's no swelling, and there's free gliding of that. I have done this twice. One was iatrogenic. I put too much volume in and I opened it up. Another one was purposeful with not a special needle. But this is certainly something to consider doing. And it's probably going to be moving to that way, akin to the transverse carpal ligament that we'll be doing. So it's a nice example of that. So the other thing I want you to think about is a differential. And so what caused it? And so there could be multiple causes, repetitive trauma, but certainly people with diabetes could be at risk for it, rheumatoid arthritis because of synovitis, amyloidosis, acromegaly, probably untreated hypothyroidism, just arthritis because of the synovitis could happen, and there can be tumors. So there is a differential, and that'll be important when I show a couple other pictures. And so on this patient, on ultrasound, you saw a big piece of bone. And so that's an exostosis. And so the treatment's not to just put steroids here. This patient actually probably needs to get that exostosis taken down. This patient actually has a foreign body to a wound. And so the treatment's not to put steroid up here. It's probably to get that foreign body out, or at least discuss that with the surgeon. In this patient, they actually have a tear in one of their tendons here. And so that would be important to discuss that with the surgeon too. And then this is a ganglion. And so just putting steroid up here is probably not going to do the trick. You could consider trying to aspirate that. But again, this is a case that I probably would discuss with the surgeon. So there is a wider differential, and I would just implore you to consider those in your treatment, and at a minimum, discuss it with your hand surgeons. Okay, we're coming down the home stretch. And so I think I have a couple more. And so, this could be me trying to keep up with my son, and I felt a pull and pain in my finger. And then you see this kind of obvious space in here, or if you will, bowstringing. And so this is kind of a rock climber's finger. And the classic is bowstringing of the flexor digitorum superficialis, because we've torn these ligaments here. And so usually you tore A2, and then we'll talk about the treatment, but you can kind of tear them in order. And so then you see this classic bowstringing of the superficialis tendon. Again, it's not a subtle diagnosis. Reminder of the tendons, of the ligaments you have here. And then when you throw on your ultrasound, you just see all the swelling and ecchymosis because of that. And then if you compare that to a normal finger, you won't have that. So again, it's not that subtle a diagnosis to make. Probably the treatment's more important. And fortunately, this isn't, you don't have to memorize this. You really have to have multiple ruptures that you need to have that surgically taken care of. Otherwise, we treat that closed. And so again, multiple ligament ruptures. And for me, really, if A4 is involved, or they've torn their lumbricals along with A2 and A3, then those need to see the surgeon. But again, most of these are taken care of closed, and really these more complex ones need to see the surgeons. Now, taking care of rock climbers, and it's difficult to shut them down. And so good luck with you. But again, this is the treatment paradigm. So again, most of these we can take care of ourselves on there. And this will be the last ones we have, and then we'll end. And so I don't want you to forget about kids. They're a little bit different. And so there's something called a Seymour fracture. And not only is this important for taking care of them, but this has been on CAQs I've seen before. And so you may see this and say, well, that's just a simple subungual hematoma, but don't forget they have a growth plate. And so when you x-ray that, that's actually a fracture of the growth plate, and the nail bed becomes interposed. And so it's really an open fracture, and they're at risk for infection, non-union, and that needs to see the surgeons on them. So, if you see this in a kid, at minimum, you got to get an x-ray and make sure you're not dealing with a physeal fracture for appropriate management. And then finally, this person has a growth fracture here. And so they have a Salter-Harris 4 fracture that goes all the way through both the metaphysis and the diaphysis, the epiphysis, the diaphysis, and the growth plate. And so they really need to get surgery. And so there where you see a pin here too. So in kids, you got to get an x-ray. Don't just treat them the same as adults. Remember, they have open growth plates. And so let's just wrap up what we talked about, and then I'll turn that back over to Myro. So again, keep all mallet fingers in extension for 6 weeks continuously. Do not miss a central slip injury, or else you're going to get a boutonniere deformity. And then if they can't flex their DIP or PIP, you got to be worried about a jersey finger or flexor digitorum superficialis. You should refer those to ortho. Boulder plate injuries should be kept in extensions block. You do not want to have those things extended. And then be wary of avulsion fractures, especially more than 2 millimeters, and especially on the radial side with a collateral ligament injury. And then for trigger fingers, up to 2 steroid injections. And then be sure you know the reason why they're having trigger fingers. Not all of them need to be treated just with steroids. They may need something else. And then you're really just referring those type 4 pulley ruptures, or the complex ones. And then don't miss a Seymour fracture. And then be on the lookout for your physeal fractures. And then in my world, almost all finger injuries need radiographs. In fact, I need to prove to myself why they don't need radiographs. And I think that's the last one. So I'm going to stop sharing and then turn that back over to you, Myro.
Thank you, Dr. Leggett. That was really great. I will go ahead and share the questions here. So Get this going. All right, so, oops.
Oh, you gave the answer away.
I know, that's my bad. So again, I have the first question here. I'll kind of read this for everybody to see. It's a football player presents to you following practice with an injury to his right third finger. On exam, he has a positive Elson test. You are concerned that this injury may go on to develop a boutonniere deformity. Which of the following correctly describes the mechanism causing this deformity? Went ahead and we have Andy put up the poll so everybody can kind of answer. It's all anonymous. You can see the answers there. If you kind of turned your head away from the screen and you didn't see what the answer was, there's the answers. Then Andy, will we just give it another 5 more seconds? All right, there you go. So that is the answer right there. Most of you got it for A. It's going to be the rupture of extensor central slip of the PIP with subsequent volar displacement and contraction of the conjoint lateral bands. And this is from your talk earlier. I think Dr. Leggit kind of put it out perfectly as far as like the unopposed flexion of the flexor digitorum profundus, and you still had the lateral bands intact. And then again, with that central slip disruption, you can see that can lead to your boutonniere deformity.
And the only clarification, Myro, is it's the flexor digitorum superficialis that's actually pulling that middle phalanx on there. But the test question was with the volar migration of lateral bands on there, just to be ticky-tacky. But the FDS is actually pulling that middle phalanx down.
That's my correct. Thanks for correcting me. Then here are the tests that Dr. Leggit had pointed out earlier, as far as using a surface to kind of have that finger kind of testing. As far as if you have that normal, you'll be able to have that supple DIP, and abnormal, you can see it has that rigid. As far as it's starting to come a little bit more dorsal.
Yeah, and that's just the reverse, which I actually use a little bit more myself. Same principle.
All right, for your second question, overall, we have during a basketball game, a 20-year-old collegiate basketball player jammed her fourth finger on her dominant hand. When evaluated on the sidelines, she is unable to extend her finger at the distal interphalangeal joint. She is taken to the locker room and x-ray reveals no fracture. What is the next appropriate step in treatment?
Wait another 10 seconds if that's okay.
Sounds good. All right. Here we go. So as far as for this is apply a stack splint. So from here. So again, this is our case of the mallet finger without evidence of fracture. I know Dr. Leggit kind of talked about that it's you might get away a little bit less of treatment time if there is a fracture, because it's kind of that bony healing will take place in the first couple of weeks, but overall it's going to be a stack splint for 6 to 8 weeks continuously. And remember, it's continuous. So they should be doing that 24/7. And Dr. Leggit, do you have anything else?
The only thing I would just hammer, again, it's near impossible to change this themselves. And so probably at a minimum, I would have them, watch them do at least one splint change, or, have your nurse or medic help you do that. Because I can tell you by personal experience, it's near impossible to change it by yourself.
Perfect. So those are our 2 questions. And Dr. Leggit, to kind of go into question and answer session, I have one question here that says, when you mentioned to not splint a subluxed mallet finger, To clarify, would treatment be to attempt reduction and splint if reduced, otherwise send to surgery?
Yeah, that's exactly right. You need to reduce that. And if you feel comfortable doing that and you can maintain the reduction, then that's certainly acceptable to do. I would say if you reduce it and then you put the splint on, make sure you do an x-ray. And at a minimum, you'll need to see them back probably weekly until you start to get some bony healing. But you're right, that is the treatment, whether you do it or the surgeon. If there is a large fracture fragment, you really strongly need to consider the surgeon to help put a pin inside there. But you've got the treatment down, so that would be acceptable.
Perfect. Okay. And Dr. Leggett, it looks like that was the only other question. I think you had a great lecture and hit all the points. I will remind everybody that join us next week at the same time. We're going to have a concussion in sports discussion, and this is the consensus statement, and it's going to be hosted by Dr. John Letty, will be your presenter. And again, Dr. Leggett, thank you so much for your time today. I hope everybody enjoyed the lecture and discussion. Thank you, Andy Meyer, for all your assistance with the lectures. And remember to complete your evaluation that Andy sent out, and join us next week for that concussion in sports. So thank you, Dr. Leggett.
Thank you. It's good talking to you. See you later.
Bye now.